treatment doses, how to diagnose the different deficiencies, and it's really easy. You can get scrolling around in the app. In the document, we have included the list of the most common pathologies where we know that there are some deficiencies which favor the development and deficiencies which are the result of disease. And these are then, per disease, those you definitively should be monitoring. We are still lacking a lot of information, so we know that this table is incomplete by definition and non-exhaustive. Of course, the most common deficiencies observed in anemia and hematological disorders, but also in dementia and cognitive disorders. The patients who come into you and when you first think, must be alcohol, hey, go a bit more into details, because actually it's much more complicated than that. And as an example, copper deficiency can manifest as alcohol abuse. So you just get it wrong. So try and go more in depth and don't stigmatize your patient saying, well, it must be alcohol. That's not the right way to go. Sarcopenic patients we know have problems. Dermatitis patients usually have B vitamin problems, lositis, and then diarrhea patients. But we should be aware about the potential toxicity of some of the micronutrients. And again, more is not necessarily better. There are 4 fat-soluble vitamins who accumulate, and actually the B vitamins may produce side effects. C also. And actually the trace elements do have either acute or chronic toxicity. The acute toxicity is generally in the context of an industrial issue, an accident. But you also know that many people think that, well, I got a box of pills. I don't want to take them every day. I'm taking all at one time. Not a good idea. Because then you accumulate. So compliance of the patient and discussing what the patient is doing is really important. And then the minerals, we're not covering them in the ELL because that is another issue. So the prevalence of nutrition-related conditions, including micronutrient deficiencies, has been just increasing anemia, inflammatory bowel disease, obesity, protein, energy, malnutrition. And you find iron deficiency across these, and they can present alone. So, facts from the World Health Organization is that iron deficiency is the main cause worldwide of lots of problems. 9 out of 10 anemia sufferers live in countries, developing countries. Every second pregnant woman and 4 out of 10 preschool children are anemic. And many developing countries, iron deficiency anemia is aggravated by worm infections, which cause blood loss in 2 billion people. Malaria, we're fighting it progressively, but it's 500 million people. So depending on where you are in the world, the causes for iron deficiency are different. And in endemic areas, malaria is the primary cause of severe anemia. It has an impact on pregnancy for sure, and health consequences include premature birth, low birth weight, infection, and elevated early mortality. And in children, it's physical and cognitive development that is impaired with low school performance. And maternal death are due to it. We now also know that iron deficiency in our Western countries contribute to the depression in teenagers who are not eating balanced diets. So if you come in with a kid, a teenager who is very tired, everybody thinks a teenager, well, okay, but he's not eating well most of the time, getting iron deficient, and nobody really aware of it because he's eating selective diets, only carbs, etc. You will not get a psychiatrist very quickly because we're missing them, but you can already do a blood testing and see if there's something you can correct. So, deficiencies are part of the disease, but they're also a result of the disease and of their treatment. These you find across all pathologies. This is why we encourage evaluation of the status when you have undesirable body weight or body composition, insufficient growth, prolonged restrictions for whatever reason, evidence of malabsorption, suspicion of specific deficiencies due to the context, and the risk groups. Because there are risk groups where you should be focused much more: infants, children, actually teenagers, elderly, and those with alcohol use, and in prolonged acute diseases. Actually, old age is a cause for that because absorption is not normal, often chewing problems, often not eating very much, so there are multimodal reasons. Symptoms are non-specific, that's the problem. And actually common for separate and complex deficiencies, often overlapping, and symptoms of underlying disease different to find out. The specific ones can also be overlapping. So without that, you don't find out. This should all be attracting it. I mean, it's so general. You get me? I'm advocating much more micronutrient determinations than before on the first visit. Like Karen showed you, in this apparently healthy woman coming in for osteoporosis. She had several deficiencies, but she did it just on the first test because then you have the chance of getting it reimbursed. And actually, the specific symptoms of vitamin deficiencies are difficult. Well, of course, there are some which are clear. The dry and wet beriberi for the thiamine, neurological and cardiac impairments are rather specific. But I mean, when you have in the ICU a dilated cardiomyopathy, not that sure that you think of acute B1 deficiency in first rate. So this is why, because not getting labs immediately back, we often encourage in the ICU to start with high dose of thiamine, whatever patient. If the patient stays with you, you can do determination to start with and look at what it was. But this is also true that how can you watch out for mitochondrial dysfunction in B2 deficiency? Clinically, no, absolutely impossible for me to do that. No? But well, some patients come in with pellagra rash or acrodermatitis, well, then you might be thinking of B3. But in the ICU, no. So actually, there are a few variants and symptoms which are calling for more specific vitamin deficiencies, but clearly not all. I mean, scurvy, with the pictures Karen showed you about the gingivitis and so on, are things you should be watching out for. Ask the patient to open mouth and see that. That can help you quite a lot. For treatments, it's also the same issue. Actually, of course, decreased growth. The child is not into the normal curve, the normal percentile. Watch out for iron and zinc. That is something you should be looking for. You have an anemia or maybe a picture of an abnormal result. You would go for iron and you would go for folate and B12. So again, we have exact pictures, but in the clinical settings, not easy. So there is one we don't talk much about, but which is a worldwide problem. It's iodine deficiency. And for those working in Northern American countries, there is no iodine in the products you have on the market, while the needs are absolutely constant. And deficiency affects, well, near 1 billion people worldwide, 13% of the world population according to WHO, and poor and pregnant women And preschool children are those who suffer most clearly from not administering it to the woman during pregnancy. I'm living in Switzerland, a rich country, asking pregnant colleagues what they're taking. They have not been prescribed iodine, while they should be receiving additional amounts. In Switzerland, I mean, we are a country where iodine deficiency is a reality. And so it takes the general practitioner to be aware about a few issues and to recommend during a control. Because the diagnosis of iodine deficiency is based on urinary iodine, meaning collecting over 24 hours, the criteria are very well defined, and it's very widespread. You've heard about alpine cretinism? Oh, that's occurring in the Alps, truly. Why? Because iodine is not present in the food, and you have to add it to the salt. So that is brain development. Think of that. A woman who's pregnant, not receiving sufficient iodine, and there is a baby there. The brain will be affected. So you have to take care. But there is toxicity also. These symptoms exist. If you're taking high doses of niacin, you get rashes, flushes, rashes. If you take too much vitamin A, retinol, chronically, risk of fracture in your hip. Peripheral neuropathy of too much B6. Liver complications, also brain complications of manganese. Liver dysfunction, if too much of some, etc. So clearly, our micronutrients are something which have a therapeutic range, and there is deficiency and there is toxicity, which is the reason why one size does not fit all, and you have products which are the same vials, whatever the size of your patient. So, in obesity, obese patient, as Karen just said, is malnutrition. In non-operated patients, look at the list of micronutrients which are deficient. After surgery, the picture is getting worse. And it's due to lifestyle changes, energy restriction, medication, reduced intake. Most obese patients have had multiple courses of food restriction to try and lose weight. And they have been eating wrongly all the time. And then they catch up, and they catch up wrongly. So obese patients are a mess for themselves. And they need help and counseling. So clearly, the lab assessment should be part of these patients' follow-up. After bariatric surgery, there are specific multi-micronutrient supplements designed for post-op obese patients. They are not reimbursed in many countries, so they are on the patient's own cost. So clearly, also there are programs to follow up. And this is typically a complement designed for an obese patient. Look at B12, 14,000 times the DRA, vitamin D3, 1,500 times the DRI, and 400 times the chromium, 500 times the iron. These are proved complements for chronic use in obese patients. It's huge amounts, but this requires monitoring. The liver cirrhosis patients and metabolic dysfunction associated liver patients also have problems. Zinc is in the first line with B12, but also the liposoluble vitamins selenium and B6. It's decreased reserves because the liver does not store the normal way it does. We don't have year-long stores for most of micronutrients, but we have it for a few weeks. Often low dietary intake, the appetite is bad, diminished absorption because the metabolism is wrong all the way, and catabolism. These patients have higher metabolism than the others. And due to several hormones not at the right level, they have malabsorption, maldigestion, and they are on medication which often have impact. The chronic intestinal failure patients also are category here. You see a long list of vitamins and trace elements which have been proven repeatedly to be at risk of being deficient. The problem of deficiency is, yes, you can live, but your function of the organs is not optimal. So you aggravate your condition by not correcting these deficiencies. And it's again the same mechanism, malabsorption mainly and reduced intakes. So the course is worsened when you don't correct, and we insist on that. And in our guidelines, we exactly tell you how you should be going on with this in chronic intestinal patients who require home care and how you should monitor. And the micronutrients are an important part of this guideline. Yes, there are challenges, and the needs change over time on the top of that because, well, with these intestinal failure patients, you have surgeries, you have sometimes reanastomosis, and on the top of that, these patients have a difficult life, quality of life is low, their compliance varies, so there's only one way, which is to monitor. IBD, same issue, you find the same line of things. For sake of time, I'm not boring you with it. But clearly, disease-related malnutrition in patients with inflammatory bowel disease is something which is very well documented. At least a quarter of the patients suffer specifically associated micronutrient diseases. Then we have a very special situation, which is a patient who has been on parenteral nutrition for some time, is recovering. So you are going to shift over to enteral and hopefully to oral at some stage. This is an amazing paper coming with this pediatric, which showed that actually transitioning between the different ways to feed the patient will be associated globally with 50% patients not covering their needs. So this affects especially copper, zinc, selenium, vitamin A, D, and E. And this is also important in the hospital, in the ICU especially. You know, we are recommending whatever the feeding route to go progressively. You never fulfill. But this means that the patient with acute disease is not covering their basal needs. So there are many ICUs who deliver multi-micronutrients, those from PM, those doses, we're delivering nutritional doses for the first 5 days until we are reaching and fulfilling those. We deliver liberally timer. In hospital patients, ward patients who have not been eating a lot also deserve oral thiamine early and screening for hypophosphatemia. So, for refeeding, which is an important issue, we have written important recommendations because there are patients who are at higher risk of refeeding. And then you have, while wanting to do good things to your patient, the risk of actually harming them by reintroducing feeding. So you should really be watching out. One of the ways we use in the ICU, which works very well, is to monitor daily phosphate to see what is happening. Phosphate and potassium, if they go down, we know we should be very worried. The strategy of progression of feeding is contributing to avoiding catastrophic responses. And in our guidelines, you will find actually these recommendations of progression according to the level of risk of the patient to have a refeeding syndrome. It's much more frequent than people know about. And then our patients usually come in on medications. We're also insisting in the guidelines on the fact that some drugs which are prescribed a little bit too liberally, like the PPIs, are causing lots of deficiencies because they alter the gastric physiology and the absorption is not happening normal. So look at the patients, what they're having as medications. All of the lipid-lowering medications will have an impact by different mechanisms on the liposoluble vitamins, but also on some trace elements. So if they have been taking this chronically, when they come in, watch out and at least cover the basic needs, because they are probably on the low side. If you are in ambulatory practice, you might actually be determined. So diagnosing deficiency in chronic disease is something that requires observation. You need to examine your patient. Always look at what is happening to the skin. Do a medical assessment and a medical history. The complement in chronic disease is just to address the objective losses of micronutrients in some cases, to address the issue of below normal intakes and malabsorption. So again, as I showed you for the trace elements, the aim is not to go high, it is to get the patient to within the normal range, to re-execute the normal biological functions. So it belongs to the treatment of chronic diseases. You have to question if there is an active inflammation present, if there is a change from normal in the behavior, in the intakes, and to consider the option of micronutrient deficiency as being a contributor to the worsening of the condition of the patient. So the key message is here that micronutrient deficiency and toxicity can be the cause of a chronic disease. They can be a risk factor for developing or worsening the chronic disease, the result of those diseases, and part of or a separate nutrition-related condition, and the consequence of the treatment modality for a nutrition-related condition. So suspect widely deficiencies. When you see the patient for the first time, widen your initial blood testing to see if something is wrong and include actually determination of inflammation level. So diagnosing micronutrient deficiency requires careful medical, clinical treatment history. Also, a dietitian can help you assess specific ways to eat, some special eating patterns, and monitoring blood levels at intervals in those who require home medical nutrition therapy is very important and actually cost efficient because it reduces complications. So, considering the low level of evidence in favor of systematic supplements, only demonstrate that deficiency in risk group should be specifically addressed, but we have quite some risk patients. And here is the reminder of the publications we have available, which are delivering you much more. The web application was in preparation, is now available, so you can really go and look for this. Thank you for attention, and now